Good afternoon. My name is Shelby, and I will be your conference operator. At this time, I would like to welcome everyone to the National LAN Event Conference Call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Lindsay Kirsch with NCC, you may begin your conference.
Thank you very much. Good afternoon, everyone. Thank you for joining us for the National Learning and Action Network event, part of our quarterly Sharing Knowledge, Improving Healthcare series. We're very happy to have you with us today as we discuss this very important topic of effective co-management of mental and physical chronic conditions. My name is Lindsay Kirsch, and I am a Program Manager for Intelligence. I work with the Quality Innovation Network National Coordinating Center, or the QINNCC. A few reminders and housekeeping items to go over before we get started today. Thank you for joining us in the WebEx Event Center. To join the event online, you will need to access your registration confirmation email and registration ID to log into WebEx. My colleague Karen Tenkate from the Quality Innovation Network National Coordinating Center will be monitoring our WebEx chat board, so please be sure to participate as we go along and feel free to ask your questions there. Slides, resources, and the recording from today's session will be posted to the QIOprogram.org website under the News and Events tab. Some of the resources are already posted there, and I know Karen will be putting the link to that in the chat. So let's start by reviewing today's agenda. First, I will go over the continuing education details. Then I will introduce each of our 3 speakers today. We have Christina Gauthier with the Center for Medicare and Medicaid Services, Eric Christian with the Center of Excellence for Integrated Care, and Dr. Paul Chinovsky with St. Page Health. There will be 2 separate facilitated discussions, one after Eric's presentation and one after Paul's. And finally, I will wrap up with a reminder to complete our post-event assessment, and we do have a plug for our upcoming calls. So I'd like to take a moment to remind our participants about the important purpose of this series of learning and shared events. So without reading all of the content on the slide, I'll just mention a few high points. Our audience is very broad and inclusive of a variety of healthcare provider types, partners, and patients. Our purpose is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. We would like to ask that you all think of actionable ways to implement the ideas and concepts presented today and to make a commitment to share the information with your own team. And finally, we are always open to new ideas and suggestions for topics to bring to this audience, so please feel free to send your ideas through the chat and or through the post-event assessment. To address the purpose of today's event, we are aligning with the Centers for Medicare and Medicaid Quality Strategy goals to promote effective prevention and treatment of chronic disease, and Chris will be talking about this more in just a minute. So to address the direct purpose of today's event, we will prepare healthcare quality improvement professionals to identify and implement effective healthcare strategies by exploring promising practices that integrate mental and physical chronic disease treatment and prevention. And we are hoping to make this as interactive as possible, which can be challenging given such a large audience. So we ask you to commit as individuals to be attentive, active, and actionable, thinking about all the ways the content is relevant to your work and priorities. Okay. So we welcome your active participation by clicking the green check in the WebEx application. You can click the conversation bubble and choose yes in the drop-down menu to commit to being attentive and active participant and actionable. We are also very excited to now be offering continuing education credits to all attendees for participating in today's session. Based on feedback provided during our last event, we will be offering credits to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We are also offering certificates of attendance. Should you have requests for additional accreditation types, we welcome those suggestions as well, again through the chat or the post-event assessment. We do have a disclaimer from our partnering provider, CRW Associates. This activity awards 1 AMA credit hour for physicians and physician assistants. We are offering CE, CEU credit for physicians, physician assistants, pharmacists, pharmacy technicians, registered nurses, nurse practitioners, and dietitians. So this activity does award 1.0 contact hour for nurses and 1.0 continuing professional education unit for dietitians. And this slide contains the accreditation statements for those entities. And certificates of attendance will also be available. And we'd also like to report that the planners and faculty for this event, CRW and Associates, and Pelican do not have any relevant financial relationships to disclose, nor was any commercial support received for this activity. And you can reference the slides for the full disclaimers and disclosures. In order to apply for continuing education credit, you must have attended the entire event. Complete the post-event assessment and the CE evaluation that will appear after exiting this WebEx session at the end of our presentation. And please note the CE evaluation can only be accessed by following the application site hyperlink at the end of the post-event assessment. So in an attempt to get an idea of what types of organizations are represented on this call, we invite you to respond to a poll indicating where you are working. So another thing we're interested in is whether or not you would claim CPHQ credit if it were offered. So we'd have you put that in the chat. So the types of organizations that we have as options for polling are CMS, home health agency, hospital, a nursing home or skilled nursing facility, a U.S. patient, family, or caregiver representative, pharmacy or pharmacist, provider or practice, claims QIO, or another type of entity. We have about 16 seconds left for you to answer the poll before we close it. And then we will review the poll results very briefly. Okay, so the poll is now closed, and we're trying to just get the results here. And the results should show. Looks like most of our representatives are from a hospital. Or no answer. Some QIOs. A few provider practices. So we will move on here. So by the end of today's call, you should be able to define integrated care on a continuum and identify action steps, planning for integration and collaboration for your organization. Describe 3 models of behavioral health integration. Identify the core components of effective multi-condition collaborative care. And define clinical inertia and understand how collaborative care reduces its impact. And now I would like to introduce our first speaker. Chris Goatee is a nurse consultant with the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. Chris will talk about the CMS quality strategy and provide an overview of CMS efforts around driving safer care. So Chris, I'll turn the call over to you.
Thanks, Lindsay. And hello, everyone. I'm excited to talk to you today. And let's just dive right in. The CMS quality strategy guides the healthcare transformation activities from the federal, state, and local levels, including those that you all are working with in your community. The quality strategy mission is to optimize health outcomes by leading clinical quality improvement and health system transformation with 3 aims: better care, healthier people, and healthier communities, and smarter spending. The quality strategy prioritizes 6 goals. The topic for today's National LAN event aligns with the 4th CMS quality strategy goal to promote effective prevention and treatment of chronic disease, with an intended strategic outcome of reduced and prevented leading causes of mortality. The objectives for this goal include increased appropriate use of screening and prevention services, strengthen interventions to prevent heart attacks and strokes, improve quality of care for people with multiple chronic conditions, improve behavioral health, access and quality care, and improve perinatal outcomes. CMS CMS aims to achieve the goal and objective by collaborating with providers, state, partner agencies, and stakeholder groups to increase awareness of current and new preventative health care services available to Medicare, Medicaid, and CHIP beneficiaries. Additionally, we are raising the profile of identified preventative services that will have the greatest impact on improving beneficiary health and reducing disparities in access to and utilization of primary and specialty health care, preventative services for all populations. Our two speakers today will share their experience on achieving a few of these objectives. Today you're going to hear from two very passionate and expert speakers whose mission focuses on improving patient outcomes by effectively addressing individuals with multiple behavioral health and medical conditions while integrating physical and behavioral health care services. We're going to hear about integrated care models that prevent and treat mental and physical chronic conditions. As you listen to Eric and Paul, consider your journey to integrate and coordinate physical and mental health care practices. Where have you come from, and where are you now? Where are you going? Consider Paul's data and what you can do to make the most out of your journey and to provide the safest patient care. Just for some background, chronic conditions last 1 year or more and require ongoing medical attention and limited activities of daily living. More than 133 million Americans report at least one chronic condition, while many have multiple chronic conditions, being two or more chronic conditions that affect a person at the same time. And lastly, increased spending on chronic conditions among Medicare beneficiaries is a key factor driving the overall increase in spending on the traditional Medicare programs. NQIOs are currently working on a behavioral health task, otherwise known as G1. This work aims to increase the identification of persons with depression or alcohol use disorder in primary care settings, as well as to improve care transitions for inpatient psychiatric facilities. In order for us to achieve this quality strategy goal and make progress with the behavioral health task, we need your help. Think about your own journey while you listen to our next speakers. What can you take away from these presentations to improve patient outcomes in your communities? Thank you very much for your time. Lindsay, I'm going to turn things back over to you.
Thank you so much, Chris. It is now my pleasure to introduce Eric Christian, Technical Assistance Consultant with the Center of Excellence for Integrated Care. Eric will provide an overview of continuous collaboration and outline evidence-based behavioral health integration models. Eric, I will pass you the ball, and the floor is yours.
Great, thank you, and good afternoon, everyone. So the title to this portion of the presentation is Effective Co-Management of Mental and Physical Chronic Conditions. And just to review the two objectives that we're going to look at in this portion of the programming is that we will be defining integrated care on a continuum and describe three models of behavioral health integration. To give you an overview sort of definition of integrated care, there are many out there. This is one of many that are often seen as the ones to look at. Integrated care is care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. Again, this is one of many, but really kind of pulls in teams, cost-effective, systematic, and the patient and family as we look at it. You've heard a lot about whole person care or whole health care, and this is based on the premise that a majority of people have comorbid mental health and medical problems, but often do not receive care consistent with established practice guidelines. When we start looking at initiation of a particular treatment and the follow-up of that treatment, or pushing medication doses before switching based on recommendations, we see a lot of opportunity when looking at those guidelines versus what actually happens. George Engel is our sort of biopsychosocial representative. He's the one who sort of coined the biopsychosocial movement, and it really pulls together that we're treating the whole person at any one time. We can't parcel it out and silo out our care, that at any one time, one person has biological factors, psychological factors, cognitive, social, interpersonal, developmental factors, And of course, cultural and other contextual factors, such as their religion. We must encounter this all together when treating the patient and not compartmentalize their care. So why are we talking about integration? 71% of most severe cases improve faster with integration. Patients receiving just 2 to 3 visits in an integrated care model show broad improvement in functioning, well-being, with these changes being robust enough to last about 2 years when we look at follow-up. And most patients who attend 2, 3 to 4 visits, this is very much related, show clinically significant change. And that would be compared to usual care, which might be anything else, whether you're sharing care or you're getting care at one location. With integrated care, we see these outcomes. We also know that up to 70% of appointments with primary care providers have problems stemming from psychosocial issues. So they may come in with a physical complaint, but there are lots of medically unexplained symptoms that we're seeing, and they may stem from psychosocial issues. And that behavioral problems and unhealthy lifestyle choices are responsible for the top 10 causes of mortality and morbidity. It may be from being unsuccessful with their diabetes, which will require behavior change in order to make changes with that condition. We also know as we look at patients as they become more complex, and this will not be a surprise to you, that as the number of physical health symptoms increase, so does the likelihood of a mental health diagnosis. And so as these patients become more medically complex, they also become more mental health complex in the way that we must treat them, and it makes more sense to be, of course, looking at the whole person rather than compartmentalizing their care. To give you some of the outcomes in general, and these are very broad, integrated care decreases depression levels, improves quality of life, decreases stress, increases higher functioning, promotes greater adherence to medical recommendations and lifestyle change. This is really an important one. There are many patients with chronic medical conditions who require lifestyle change or behavior modification to meet the needs of their conditions and really show some improvement. It also reduces readmissions to hospitals and hospitalizations, and it really encourages that movement towards value-based care where we're looking at overall health outcomes and wellness, and that's how our clinics will be rated on things as we move forward. So to give you the continuum, integration really is on a continuum, and it moves from coordinated care at the left, where you see these teams in test tubes. They may be coordinating care across town. There are lots of logistical complications to that and communication issues, but we do need that to happen across clinics, from specialists to primary care to the hospital. But then as we move up and relationships increase in intensity, we have co-located care. And this would be sort of a business within a business, if you will. We don't share many systems, but we have proximity in our favor and can help patients with many of the logistical barriers through this proximity. And over time, many of these arrangements start to develop more towards integrated environments or integrated clinics. In the integrated clinic, we're one team where the behaviorist is on the floor, is working with the providers, can meet the needs of the patients right then and there, and it reduces a lot of the barriers that we see in co-located care or coordinated care. I must stress that no one of these is the only solution. We need all of these levels to be working at the same time. Integration is not a replacement for a functioning mental health specialty system. So as we look at team-based care, we think of mental health providers working together to detect, to treat, and to follow up on physical health and mental health needs of their patients. We assume that they have a shared responsibility and we're not siloing care. And they have really strategic workflows so we know who's on deck first and who does what in that workflow, and they've worked together as a team to kind of hammer that out. When we think about models, there are 3 of them. They have clear definition, practice, personnel roles. They have a clear evidence base. And these are those 3. Collaborative care, or the impact model. ESPERT, which stands for Screening, Brief Intervention, and Referral Treatment. Or the primary care behavioral health model, which is a consultant model. They're not mutually exclusive in that they can happen all in one clinic, so you can have more than two running at the same time, but they do differentiate in the populations that they serve. So this kind of just helps you to take a look at that. We have horizontal care for everybody who walks in the door, and then we've got these vertically integrated models where certain patients who meet criteria, for example, all patients with depression, might get a real specific approach where the team has really honed their skills. To look at the models in that way, you can see the arrows in the way that they delineate that. So we have primary care behavioral health with the PCBH model, which is that generalist on the floor, working with the primary care providers and the nurses in and out of exam rooms, getting a warm handoff and providing brief intervention. We have expert, where it's a screening intervention, where a brief intervention model and a follow-up registry is put into place for patients who have, in this case, alcohol or substance use disorders and need ongoing attention. And then the collaborative care model or impact, which is very registry-driven, and medication and visit algorithms are defined, it's disease-focused, and we're going to talk a little bit more about that in solo your next presenter. I'm going to skip over this slide, and you'll have these just for in terms of time. We kind of went over these. We also have bidirectional integration. This is where we have primary care providers integrated into specialty mental health settings. So sometimes it's called reverse integration. It's sort of a pejorative term. But this is where we can meet the needs of specialty mental health patients, or those with severe and persistent mental illness who are not frequenting primary care. Maybe haven't gone in years, may know that they have a health condition, but are not comfortable addressing it. And so we can get entrance into primary care in this location that they frequent, which is the specialty mental health setting. The focus is on targeted medical issues, and when we achieve stability, maybe moving them over to make room for the next patient, moving them on to a primary care clinic if needed. And these levels of integration are also on a continuum. They could be coordinated, they could be co-located, or very much integrated. And again, this service line, this bidirectional integration, does not replace the need for primary care services or more intensive specialty care, such as seeing the internist or any other specialist. You'll notice in my slides that you'll be able to download later, all of the references are there for you to look at, as well as some contact information. And I know that we have a poll, but I'm not sure if that's happening before or after our Q&A.
I think we're going to take the poll right now if you want to pass the ball back to me.
Sure, and I can walk people through it if you'd like.
Sure, that's fine.
Great. So this is just a little poll to see where you are in your level of readiness. This is something we do with patients all the time, but it really does apply to your clinics or to your quality improvement team. You know, where are you? Are you in the pre-contemplation stage when thinking about behavioral health integration, meaning that you have no interest in behavioral health integration? It really hasn't hit your radar. Or you're in the contemplation stage, that you'd like to have it, but you're not sure really where to begin. Or are we in the preparation stage, planning to take action towards behavioral health integration? Or very much in the action stage, we're actively implementing, we're in the middle of it. Or some might be in the maintenance stage, where we've got this mature system, we have perhaps continuous quality improvement going on, so we're always looking at when we and how we can upgrade our system. Or, unfortunately, and this happens even with integration, we're in the relapse, where we started behavioral health but failed, and we may be thinking about trying again. So you'll be able to see the poll here and make your selection.
I think we need Jennifer to start the poll for us. Sorry, Eric, we're just not showing up. The other thing we could do is have people chat in their response, A, B, C, D, E, or F as defined on this slide here. So we will leave the slide up for a few more seconds if you would chat in your response. Oh, looks like it's open. Thank you.
I see the poll.
All right. Thanks, Eric.
Just 15 seconds left. Great. Looks like the poll is closed. Will we be able to see the results?
I hope so. I think so. So just for the sake of time, we'll wait for the results to come up, but we are going to move into facilitated discussion. So, there we go. So it looks like top answer is inaction, and just followed by contemplation.
Excellent.
We have a good amount of people that are in the preparation phase, and just a few in pre-contemplation or maintenance.
Excellent.
All right. So like I said, I'd like to open the call up for questions and comments for Eric and his presentation. So I'm going to invite Karen, our chat facilitator, to share about any conversation happening in the chat and any questions you all have posed. Karen, is there anything in the chat you wanted to ask Eric about? Karen, if you're talking to
Karen, we have no questions yet at this time.
And Shelby, do you want to see if anybody wants to put a question in the queue for Eric? Opening line.
Of course. At this time, I would like to remind everyone, in order to ask a question, please press star 1 on your telephone keypad. We'll pause just a moment to compile the Q&A roster.
And we just had a question.
Yep, go ahead, Ken.
We just had a question come in through chat from Jim Jackson. He says, in Washington State, there seems to be confusion about terms where integrated care is presented as a panacea for the health challenges faced by seriously mentally ill folks. Do you have any thoughts on this?
Yeah.
And we have a couple questions.
We've seen a lot of that sort of just becomes the buzz, and yet when you start talking about with people, they have a very sort of broad view, and they're not really getting down to specifics. And that is one of the reasons to focus on the models that are evidence-based and to begin with them before sort of generalizing. There is a place for folks with serious mental illness to receive an integrated approach, and that might be that bidirectional. If they're not engaged in primary care, this is a way to meet them where they go most to deal with the problems that are paramount for them, and that might be the mental health provider, to meet them there, to diagnose undiagnosed conditions, and maybe get them moving in the right direction of participating in treatment.
Great. We have a few more questions as a follow-up from other individuals in the chat. From RCC questions, we have, Eric, is there a preferred mode of integration in terms of overall improvement of health outcomes? And is that kind of data available?
Sure. The data is there and available for the collaborative care model impact. It has been published in over 80 studies, which gives you a direct return on investment. People improve twice as better as usual care being anything else, whether they share care with specialists or get it all at the primary care doc. And the thing to remember, though, with collaborative care model is that it's a defined population within a population, so it's not everyone who comes in the door, but yet these are patients who you've identified as high need and can make some inroads with them. There's also the PCBH model, and you'll have the slides for that, which does have an evidence backing, but that's more of the generalists on the floor. And their impact can be more measured through looking across the population and even at speeding up the primary care providers' efficiency. So you may find that they see 2 or 3 more patients per day when the behaviorist is on the floor, and then we begin to look at the health outcomes of those that they've interacted with.
Thank you.
So I think we are going to move on now. So thank you, Eric and Karen, and feel free to continue to submit your questions or comments on Eric's presentation in the chat. We'll try to address additional questions after our next presentation. So it is now my pleasure to introduce our next speaker, Dr. Paul Chanowski. Let me just make sure I have Paul here. Dr. Paul Chanowski is the founder and Chief Medical Officer of Same Page Health. Dr. Janowski is also a clinical associate professor with the Department of Psychiatry and Behavioral Sciences at the University of Washington. So, Paul, I will pass you the ball and the microphone.
Wonderful. Thank you so much. Thanks, everybody. And I want to thank the Quality Innovations Network National Coordinating Center for putting on such a wonderful event and for inviting me. It's really great to be here. Today I'm going to present on an evidence-based model for achieving behavioral health integration. But, you know, I'm going to speak more about a model that really extends beyond that to achieve better, not only better behavioral health, but also to address medical conditions as well. In other words, this model will help us address both behavioral health, but also the health behaviors, giving us the layering on of extra care that we need to address all conditions, whether they're behavioral or medical. And that way we can also reduce silos and cost-effectively address behavioral and medical disorders, the whole person, as we've heard referred to earlier. So, speaking of disorders, I want to start with talking about the most important disorder of all, and that is clinical inertia. This is an institutional disorder, and if we don't pay attention to clinical inertia, then everything that we spend money towards as far as improving treatment, all the efforts that we put into it, will not lead to the results that we want. What is clinical inertia? It's defined as a lack of treatment intensification in a patient not at evidence-based goals for care. And it's a major factor that contributes to inadequate chronic disease care in patients with all of these medical conditions and many, many others. So in other words, what is the evidence that clinical inertia exists? If you look at this article by Schnittiel and colleagues, this is 160,000 patients with diabetes. And they reviewed the charts of these folks, and they were looking at poor outcomes, A1C, blood pressures, cholesterol. And basically what they found, surprise for them, is actually a small part of the variance in poor outcomes was accounted by poor adherence, the usual culprit that we always focus on. Actually, a larger factor to really that came up with this clinical inertia. In other words, this lack of treatment intensification. And so if you think of the real world, the way it plays out is like this. Imagine Mrs. Jones here going to her healthcare provider 4 to 6 times a year for diabetes, hypertension, hyperlipidemia, depression. And despite her earnest efforts 4 to 6 times a year going to her healthcare provider, she still can't get her glucose, blood pressure, and cholesterol in target. That's called the Bundy benchmark. I wish that this was an exception, but as you know, it's the rule and not the exception. In this country, 81% of those with diabetes, according to NHANES data, fail to achieve this bundled benchmark. 81%, 4/5 of patients with diabetes do not achieve these three indicators together. And the author said to achieve this benchmark, we need to improve methods to increase adherence to medications, physical activity, diet, and access to support, including motivation and maintenance of behavior change. So my question is, how do we do this? How do we achieve that in the patients that are languishing, the most complex patients with 5 to 15 minutes every 2 to 3 months? And the answer is we can't. We have to do something different. And that's where we get into collaborative care. But not only for behavioral health, but also for multi-conditions. Because everything that we're going to show you about collaborative care is actually very advantageous for addressing chronic medical conditions as well. The other thing to remember, of course, and we've heard this before, is that if you, particularly people that have medical conditions that aren't in target, the presence of depression or anxiety or other behavioral health conditions doubles or triples the cost of care. And that's not just an ROI issue, that's not just an issue about saving costs, but it's really about equity and having the resources to address the whole population. And so if we're inefficiently treating mental illness, then we're not serving anybody. So we're really focusing on this yellow band, the complex chronic. These are people with multiple chronic medical conditions and behavioral health issues who may also have extensive social needs. And if you think about these people, they're the top 5 or 10%. And as we know from your data and clinical data everywhere and national data, it's the 5-50 rule. The top 5% that cost 50% of the top 10% that cost 2/3 of healthcare costs. So we need a solution. We need to do something different. And collaborative care is that solution. It's a team with a shared mission using improved clinical systems to deliver care to a patient population. It's population-based care. It's supported by operational and financial systems. And this care is continuously evaluated to improve processes and effectiveness measurements. So, what does it look like? This old model that we've had is the patient goes and sees a primary care provider, and I would say that this model is so 1990s. Well, it's actually so 1950s. And thankfully, since the latter part of last century and into this century, we started to add care management. Case management, care management, and it's wonderful. And it's done a lot, especially for those people that are languishing, the really challenged patients. But we have to go one step further, and that's what collaborative care provides. It provides what's called systematic case review. It's the clinical secret sauce that differentiates this from all care management models. And what systematic case review does is it's a weekly overview of the whole caseload, not just the people that showed up or answered the phone, but we are accountable as a team for everybody on that panel. And we have to figure out not only how do we make their outcomes better, but how do we keep them in treatment? How do we work within the healthcare system? And that case review is done very efficiently on a weekly basis with a psychiatrist and a medical case reviewer. And those psychiatrists and medical case reviewers aren't the patient's providers. Then action steps are determined and then conveyed to the PCP that week. So this isn't a siloed program where 3 months later there's a report that may or may not show up. No. This is where the PCP is apprised of some suggested codified consultation recommendations that then they can divide and conquer and make action steps. So the whole idea here is that in 3 months, with weekly contact with the patient, you can have 12 contacts, 12 touch points versus the usual 1 touch point in usual care. We talk about usual care. This is unusual care, as in uncola. This is different. This is care that really has figured out this whole critical inertia part. So we published a study about 4 or 5 years ago, and this was in New England Journal of Medicine, and this was the first trial where we expanded this beyond just looking at depression. This was looking at depression, hypertension, hyperlipidemia, and diabetes glucose control. And in that study, we focused on the ABCD, A1C, blood pressure, cholesterol, and depression. And what we found is that we had wonderful results. So if you compare line by line, depression that we got in the shaded column with the meta-analyses of depression studies that just looked at depression, we had an enormous effect size. Effect size is the difference between means divided by standard deviation. And what we had is a very robust effect size, where on the whole, collaborative care trials that were done, this was an earlier publication of 37 collaborative care trials, the effect size is 0.25. And so on, you can see that A1C results were comparable to studies that looked at diabetes trials, and then similarly, systolic blood pressure also comparable. Remember, this was one care manager per patient addressing all of these conditions. We also improved LDL, and at the end of the day, we saved cost. So net saving of cost, improved access, and better outcomes. I know that all rings to you as triple aim. So the other thing to remember is that we're really addressing this through more medication adjustments in 12 months. So the key here is not only that the intervention, the collaborative care, the blue bars, is better than the control group, the pink bars, but the key here, the real story here is that in usual care, the pink bars, maybe pink because it's embarrassing, is that in 12 months, people with depression, major depression, who are on antidepressants, only 30% of them had 1 or more medication adjustment. If you go down to insulin, only 30% of those that had A1Cs over 8% had any adjustments in 12 months. We have to improve on that, and that's what collaborative care does. So in an implementation that we took not so long ago with a large healthcare system, we chose people with depression, with out-of-target diabetes, with hypertension. And when you choose on those three factors, we have people with a mean of 9.6 chronic conditions, and we found that in a median duration of 17 weeks, we could achieve these results. I just focus on a couple of them. We were able to reduce the proportion that had major depression by 74%, the proportion that met HEDIS goals for A1C by 69%, and improve the number of patients with HEDIS goals for A1 blood pressure by 29%. And the kicker is we found that we also reduced ED visits by 50%. So just quickly, we identify goals not only of the patients, starting at the top here, but also of the team. We close those actions on those goals and action steps. And here are those strategies. Frontline providers use problem-solving, decisional balance, self-management support. And in the bottom sections here, monitoring progress, treat to target, and systematic case review. This is all about measurement-based care and making treatment titrations readily, reviewing it in a systematic case review, and then immediately conveying some suggestions to the PCP. That PCP ultimately has a decision about what's executed and what isn't as far as action steps, and we divide and conquer. Therefore, we really move to action very quickly. All of this is nested within a framework where we choose patients based on a registry using both claims and EMR data. We enroll patients, put them through this program, and then move them to maintenance once we achieve our goal. For example, A1C, blood pressure, and cholesterol. The big startling thing that's jumping out of this slide is the red arrows, of course. It's all about data in and data out. This team, this weekly systematic case review, will review the data, the most recent THT lines, GAD-7s, blood pressures, blood glucoses, if there's an A1C, and so on, and we come up with action steps to convey to the team so that we're making a lot of treatment titrations quite quickly. I'm going to just finish with a couple of last slides. I want to say that as we think of disseminating this, one study by Courtney and colleagues looked at FQHC where they implemented collaborative care, and they compared telemedicine-based centralized collaborative care that included centralized systematic case review with practice-based collaborative care. And what they found is that the results were 3 times better, 3 times more robust for achieving depression outcomes. And really, it's not that people on the front lines can't do it, but often practice-based care managers are doing 3 or 4 other things. There's turnover. There isn't centralization of the method and methodology. There's attrition of skill sets, and that plays into it. But there are many reasons why I think this is important to recognize that really one of the answers in many centers would be to centralize parts or all of this, and there's evidence that it works. So to finish, we're addressing depression and comorbidities through psychoeducation, administering screening for comorbid conditions and self-harm, reviewing and titrating meds, addressing side effects, using evidence-based methods such as problem-solving, behavioral activation, decisional balance, and relapse prevention. So in summary, we're addressing depression and anxiety in a setting of comorbid medical conditions. There's been a lot of hype about analytics, identifying gaps. This is the how to the analytics what. We're addressing not only behavioral health, but health behaviors, and it's truly a population health approach. The benefits are rapid improvement, reduced silos of care, the biopsychosocial model of George Engel that we heard about, inclusion of PCPs every step of the way with built-in curbsides from both psychiatry and internal medicine, and others if they're available for the systematic case review. So I'm going to stop there for questions. Thank you very much.
Thank you so much, Eric and Paul. So we're going to open this up for questions and comments for Paul and his presentation. So again, I'll invite Karen, our chat facilitator, to share about the conversation happening in the chat. I know, Karen, that you did send me some questions that were related to Eric's presentation, so I first want to see if we have any related to Paul's, and then we can kind of go backwards. Karen, anything in the chat about Paul's presentation?
Hi, Lindsay. This is Karen. We have 3 questions after Eric presentation that were not addressed yet, but I think either Paul or Eric could answer them. They're broad.
Okay, so I think one of the first questions, do you want to read them, Karen?
Sure. SAMHSA has been funding pilots around the country for a number of years. Where have you seen the most successful implementation of medical care for persons with serious mental illness, and would you share about those models? Are there any that jump out?
So I didn't hear the first part. What was the first part?
SAMHSA, and I'm at a loss on the exact, what the abbreviation is.
CMS, okay. Can you read the question?
SAMHSA, the mental health agency.
SAMHSA, right.
SAMHSA has been funding pilots around the country for a number of years. Where have you seen the most successful implementation of medical care for persons with serious mental illness? And would you share about those models? Are there any that jump out?
Well, so I would, I'm going to stick to what we've been presenting here, which is focusing on primary care populations, looking at depression and anxiety. Some of the people may have had serious and mental illness. But when we think about what organizations we work with, including, in the past I've trained up, we worked with New York's Health and Hospitals Corporation, where they had a large Medicaid segment of the population, dual eligibles, and then other organizations that have mixed payers. And so I'm really not focusing as much on serious and persistent mental illness here.
Okay, thank you. We have another question recently that relates to it. Which organizations, I think this person wants the organizations to be named, which organizations are currently using the collaborative care model that you just described?
Sure, and so again, remember this is collaborative care that expands beyond just depression care. So we've worked with Mayo Clinic. I've over the last 5 years worked with implementing Mayo Clinic, Kaiser, currently working with Trinity. We have worked with Providence, Swedish Medical Center in Seattle. We're working with UCSF and other organizations that are interested in this.
Thank you. We have a question about billing. This person is Elisa Stansberry. She's on a community-wide collaborative working toward a co-located care for primary care and behavioral health. And a big question or stumbling block exists around billing for mental health therapy services on the same day as a beneficiary sees a primary care physician. Can you help with where we can find information on what to expect regarding reimbursement if we bill on the same day? And I'm thinking she's talking about SQHC, but I'm not 100% sure. It sounds like a small detail, but an answer would be super helpful. And she said, thank you.
Sure. I can answer it more broadly about reimbursement for this model, which is that most organizations that are interested in this are moving to value-based care. They have at-risk populations, and they recognize that the very people that we're talking about here represent the top 5 to 10 to maybe 15%. And so they're utilizing this model to address this in a value-based risk-sharing kind of contract system. As far as fee-for-service, what I do know is that there's a change within Medicare or CMS to include reimbursement for collaborative care using a physician fee schedule starting in 2017. As far as the nuances of same day, what do you submit on the same day? I'm sorry, I can't answer that at this time. I need more specifics.
I can talk about it a little bit. This is Eric. It kind of depends on your state. I mean, outside of Medicare, it kind of depends on your state when we think about Medicaid. Some have gotten a little bit more progressive where they allow billing of psychotherapy and an E&M code on the same day, and others are a little bit behind. So it's just something to kind of look into. And you'll bump into that again even with those new CMS codes, because although it accounts for lots of the functions that are non-face-to-face within the impact or collaborative care model, the face-to-face interactions still get billed for psychotherapy. So if you can or can't on the same day, then that still can become a little bit of a glitch. But there are lots of ways to work around that with team-based care, where we know that a brief introduction, even though you may not get a billable event out of it, leads to higher levels of sure rate for follow-ups. So there's a lot to kind of think about, and I did post in the chat a SAMHSA page, which gives you the financial billing by state, but I do caution you to check it with your local Division of Medical Assistance, because I know we found errors in both the New York version and the North Carolina version and made corrections with SAMHSA, so your state may need to review it.
Thank you, Eric. And this is Karen. Did you chat that to all participants? Because I'm not seeing it.
I thought I did.
You might want to go back and read it.
Yeah, it says to all attendees, but I'll see if there's another option there.
Okay, thank you. You want all participants. The attendees will get it. The audience will get it.
Got it.
We have another question from the chat. Are there any questions on the phone line at this time?
Just as a quick reminder, in order to ask a question over the phone, it is *1.
So while we're waiting, we have one more question from the chat earlier, and it says it's from Francine Davis. She says, how effective do you think telepsych is as a part of integrated care?
Was that health psych?
Telehealth?
Yes, telepsych, absolutely. So that second to last slide that I showed, that was about telemedicine and comparing that if you ask my telepsych. So what I would say is that this uses telehealth, but it's not necessarily just full-blown telepsych. Telepsych assumes that there's a psychiatrist there, and what we know is that when we're addressing a population, not every single person needs a psychiatrist. So in this model, only a small proportion of people have to see a psychiatrist one-to-one for a diagnostic clarification, and so that might be like 10 to 20% in our experience, both in clinical trials and in real-world implementation. About 80 to 90% of the people that we identify do not see a psychiatrist. The psychiatrist hears about the cases in the systematic case review. However, 10 to 20% might need a psychiatrist, and there, in that case, a telepsych component would be useful.
I would agree, and they may or may not be appropriate for that model. You'll find enough patients that will be appropriate, and I know in the collaborative care models that we have, we're looking for that defined metric by the AIM Center that up to 70% of patients at any one time has had a chart review by psychiatry. Then we know that we're doing due diligence in that caseload, and usually it's above that anyway. Whereas only 2% of our patients and we're dealing mostly with depression, bipolar disorder, and anxiety, only 2% are actually getting that face-to-face, or they may just not be appropriate for that registry, and that's fine. There are enough patients who will be.
Thank you. I believe we have time for just one more question, if there is one out there on the phone line. Is anyone trying to dial in on the phone?
There are no phone questions at this time.
Karen, this is Lindsay. I do see one in the chat I'm not sure we got to yet, asking about how do other vendors see substance abuse fitting into these models?
Oh, thank you. I saw some conversation around that, so I was reading that to them. Yeah, how do you see substance abuse fitting into these models? It's a great question that we do have time for.
Eric talked about that first, so Eric, why don't you go ahead and start?
It's all over these models. If you're not screening for it and treating it concurrently, then you're just missing opportunity. So we need to know the prevalence in each of these populations and which screening tools are better to use to get to the root of the matter. We see it in all of the models and address it concurrently. It is really the only way. And studies have shown if those questions are asked by your primary care physician, the provider that you have longitudinally over time that you trust, that simple screenings and normative education around that do lead to reduction in risk, if not abstinence. We're really looking for harm reduction in this primary care model by educating and screening patients and providing ongoing attention to those identified matters. So it really is pervasive.
And I would just add, go ahead. Sorry, I just add that, Eric's matrix of vertical and horizontal integration, I think, for collaborative care, we might screen out current substance use have that addressed, and then bring them back into multi-condition collaborative care when that was addressed.
Right.
Thank you. We have time for a 30-second answer on this last question, and it's really important because it's related to access. James Gendron writes in, do you find that integrated care opens up access to specialty psychiatry, or does it allow more patients to be seen in general?
Well, I can answer that. I mean, yes. I mean, every single patient that goes through collaborative care has the input of a psychiatrist. That's why PCPs that are engaged in this in the community really appreciate that, because on a weekly basis they get a curbside consultation from a psychiatrist. Again, a proportion of those people might then have a diagnostic clarification or evaluation by psychiatrist. But what you're really doing is leveraging the model so that in a cost-effective way, you're taking the expertise of a psychiatrist and now applying it to the whole population as opposed to just 5% or 10% of the population. And so it absolutely allows more people to be seen. That's the whole beauty of the collaborative care model. That when we started this 20 years ago, we were doing this for that very reason, leveraging the expertise of the psychiatrist to weigh in on all of these cases and then delivering that information directly to the PCP so that they could make the changes and we could get the outcomes that we're all expecting.
Thank you so much. Now, Lindsay's going to wrap up our call and tell you some important information upcoming.
Thank you, Karen, and thank you, Paul and Eric. So I'm going to call to action. Now that we've heard from Paul and Eric, I have an ask for all of you. First, consider if one or more models of integration might fit your organization's practice site. So the question is, what resources and adjustments would be needed for this model? And we have some examples here on the slide. Paul has provided 2 articles and an infographic on his collaborative care model. These are posted on the QIO program website, and I think Karen has linked those, shared those links in the chat. So we encourage you to review these resources and share them with your colleagues and partners. You can start applying today's strategies and best practices immediately. And also, do you have a story to share? Has your organization experienced successful integration of behavioral and physical care? On the other hand, what are some of your challenges? We'd love to hear these. You can share them with the Quinn NCC by emailing Nikki Rosales. Karen will include her email in the chat. And these stories can help guide the content for our future learning activities. And, Karen did put Nikki's email address in the chat. And as we mentioned earlier, we would love to hear topic ideas from you all for future offerings through this venue. If you have any needs or ideas, please send your ideas through the chat. You can email us at qincc@area-d.hcqis.org. That's a lot of letters, so Karen will be putting that in the chat. I think she already did. Thank you, Karen. You can also provide any ideas for future topics in the post-event assessment. And to ensure we have the opportunity to engage with you all again related to your actions and activities as a result of today's great session, we'd like to invite you to join us for a follow-up event. This will be on Tuesday, December 6th from 3 to 4 p.m. Eastern. We are very fortunate that Paul and Eric will be joining us again for that event, so we want to hear from you and about all the things you've accomplished, what started. And registration will be required for that as well. The registration link is on the slide, and again, the slide will be on our QIO program site, and also Karen will be putting the registration link in the chat. We'd also like to invite you to join us for the next formal National Learning and Action Network event, which will take place on Tuesday, February 7th, 2017. The topic will be focused on working with communities to promote best practices of healthy living. And there is another registration for that event that will also go into the chat. Please take a moment to complete our post-event assessment. Your individual feedback helps drive our future calls. We read every comment you make. We review and consider every response, all of your feedback. We also have Nikki's email address, which is on this slide. If you have any questions or comments, you can email your stories to Nikki. And it is the top of the hour, so if there's any last questions, please feel free to submit them through the chat box. When you do close the WebEx session, you'll be invited to share your thoughts and feedback through that post-event assessment we've mentioned several times, and we greatly value this feedback and really appreciate you taking the time to do that. I'd like to thank all of our speakers today, Chris Goatee, Eric Christensen, Paul Chasky, and of course, thank you to all of our participants for being with us today. Have a great afternoon.
This concludes this afternoon's conference.